Good afternoon, everybody. My name is Kevin Quigley. Policy enthusiasts. My name is Kevin Quigley. I'm the director of the MacEachen Institute for Public Policy and Governance. Thanks so much for coming today to join us in what I'm sure is going to be a very stimulating discussion around Pharmacare. Very topical, interesting, politically sensitive issue that I'm sure will drive a lot of policy ideas over the next 12 months as we approach an election. So we start today's event by acknowledging that Dalhousie University is located in Mi'kmaq, the ancestral and unceded territory of the Mi'kmaq. We were all treaty people. The title of today's panel is Provincial Perspectives on Federal Pharmacare. The panel aligns with our subject, Health Systems and Governance. Canadians pay among the highest prices for and spend more on prescription drugs than citizens of almost every other country in the world. On average, Canadians spend $926 per person on prescriptions per year through a combination of public, private, and out-of-pocket expenditures. A 2015 Angus Reid survey found that 23% of Canadians reported they or someone else in their household did not take their prescription medications as prescribed in the previous 12 months, if at all, because of the cost. An estimated 1 million Canadians are forced to cut back on food or heating in order to afford prescription medications. However, a national pharmacare plan may not be the only prescription to cure these problems. A report from the Fraser Institute notes there actually exists a vast network of provincial plans to help Canadians, particularly those who may be at higher risk of foregoing prescriptions due to financial considerations, pay for their prescription medications. Their solutions would, they note, support Canadians falling through the cracks. We have a slightly different format today. We're pleased to be joined by the Honourable Diana Whalen, who is going to discuss the work that she does at the Advisory Council on the implementation of National Pharmacare, just to sort of familiarize everybody with this work. And then we are going to pivot at that point to the panel and have a discussion about the policy implications of Pharmacare. So just a quick note about the Honourable Diana Whalen. Diana Whalen was the first elected to the Nova Scotia House of Assembly for Halifax Clayton Park in 2003. She was re-elected in 2006, 2009, and again in 2013. Ms. Whalen was Deputy Premier of Nova Scotia from 2013 to 2017. In 2009, she received the Women of Distinction Award by the Canadian Progress Club for her work in the community. Ms. Whalen holds a Bachelor of Arts and Masters in Business Administration, both from Dalhousie University. She also holds the professional designation CPA and CMA. Thanks so much for coming. Thanks.
Well, thank you so much, and I really appreciate having just a few minutes at the start of this important panel to give a little bit of an update on what the Advisory Council on the implementation of National Pharmacare has been doing. And the council was first referenced, I think, in the federal budget last February, and right after the Finance Minister, Bill Morneau, talked about it, he appointed Eric Hoskins, who was previously the Health Minister in Ontario, to chair this committee, this council. And it is a 7-member council, including Dr. Hoskins. The other 6 members were not approached and announced until June of this year. So we all came together at the end of June and have begun the work of how to look at the implementation of National Pharmacare. And I stress that word because when we've had all of our public meetings and roundtables and consultations, that's the word that we think is so important. There have been many, many studies on the circumstance of pharmacare in the country, and we understand that there is a need, there are gaps. And so we've been asked to look at providing a blueprint or a bit of a go-forward plan on how we could implement National Pharmacare. And I must say it gets more and more complex the longer we work on this and the more people we talk to. But we have a wonderful group of people representing the country. I am the only Atlantic Canadian on that council. So I've taken that very seriously about being a voice and being able to connect here in the Atlantic region. But we're looking nationally, and we have a great representation from the whole country. I just wanted to let you know, since coming together in June and July, we've set off to talk to each province and territory. So we've had meetings in each of the capitals to meet the public officials that run pharmacare programs so that we can really understand where their gaps are or what they feel are the good parts of their programs or the things that are lacking, just to get a very good sense. And as you will know, it varies greatly across the country. And members of our Council as well have been to the north, to the territory. So we've done all of that. No Pharmacare plan will ever be successful unless the provinces agree and are interested and want to come on board. And we would say that people that we've met up to this point, and Eric Hoskins has met with all the ministers as well, cautiously optimistic, I would say. They're interested, but they're cautious. And until they have something to respond to, we won't hear too much more than that. But they want to follow this. They're very, very, very engaged. And I think that that's really important. So this has been our listening phase. We're not done with that just yet. I want to let you know before I sit down that we are having another meeting, a public town hall meeting that's at the Delta Halifax tomorrow night, Wednesday night, 6:30 to 8:30, which is open to the general public. We have only had 3. I was explaining to others today, only 3 of these meetings. This will be the 3rd. We did one in Vancouver in the summer. There's been one in Toronto and now one here. Most of our meetings, and we've literally talked to thousands of Canadians, but they've been at invitation events, roundtables, where we invite stakeholders from many, many different viewpoints to come together and sit at tables and discuss. And we've done that in every province and territory. And they've included people like healthcare professionals, pharmacists, doctors, dentists, nurse practitioners, lots of nurses, industry people from insurance and the pharmaceutical industry. Definitely very big stakeholders in this discussion. Advocacy groups for many, many different health issues, rare diseases, and other diseases that come in, and people who are great advocates. And I want to mention that we've included patients. We're very, it's a very important thing to Eric Hoskins as a minister. He always had patients on all of his panels and advisory groups, and we actually began our very first consultation with patients, talking to them directly and having a session as well with patient advocates on our very first day in Toronto. So one of our members is a patient advocate, one of our 7 members of the advisory council, Vincent Dumez from Montreal, and he works with the University of Montreal Medical School. They have a patient advocacy sort of center there that does a lot of research. So, we do believe the first person voice is very important, and we've kept that front and center throughout. And I wouldn't want to miss the fact that we've also tried to reach out particularly to vulnerable populations. We've had a couple of meetings where we've worked very hard to get people together who wouldn't normally come to public meetings, who don't, either because of vulnerable or maybe precarious employment or lack of resources. So we've had a couple, and we're going to be having one here in Halifax as well in the next few days, so that we can, again, try and connect with people who normally whose voice would be lost in this debate. So we think that's very important. And we've made sure in our travels across the country to include Indigenous people and to have special meetings and discussions. I wouldn't call them consultations, but discussions, so that we can ensure that they know that this policy question is unfolding. It's a very big issue for the federal government. I would like to mention one thing that's special about this council, in addition to it being an implementation of National Pharmacare, which I think is important, it's that it reports to both the health minister federally and to the finance minister. And I think that this would be the first time that has occurred in previous studies and efforts by the successive governments, really, who have looked at Pharmacare in the past. And so our question to Canadians when we've had our roundtables and meetings really also includes, how do we pay for National Pharmacare? Because that's going to be the key to the sustainability and success of any plan that the government may choose to put forward. So our responsibility is not only to consider it from a health perspective, but also from a sustainability perspective. So I think with that, I would like to turn it over to you again for the panel to continue. So thank you very much, and I hope you've all written down that public meeting as well, which is tomorrow night, Wednesday night, 6:30 to 8:30. Delta Halifax, which is the hotel attached to Scotia Square, the one that's on that side of the street, and it's in the Blue Nose Room on the top floor there at 6:30 to 8:30. So you're all welcome to that. Thank you.
Thank you, Ms. Whalen. So begins our last panel of the year, the Policy Matters Speaker Series. We have a lot of other informal and ad hoc panels that we'll be planning throughout the year, but this is our last Policy Matters meeting for this fall. And I think it's a great panel to end on, such an important subject with a variety of implications, as Ms. Whalen has just pointed out for us to think about. We're going to do it exactly the way we normally do it. I'm going to introduce each panelist just before they speak. Panelists will come up and speak for about 12 minutes or so, and Tari will be keeping a watchful eye and flashing the cards to keep them on time. After the formal statements are made, we're going to call on 3 students from the MPA program who've signed up to ask questions. I say the MPA program. Actually, it's 3 students who are in the policy class. They may not be from the MPA program. And then we'll open it up for community questions. So I would just ask you to keep in mind, if you have a question that you'd like to ask, please direct the question to a particular panelist, because we want to try to get as many questions in as possible. So to ask a question of the whole panel, or anybody can answer this, or everybody can answer this, is actually like asking 3 questions. So I'd encourage you to think who's the best fit for your question and point that question to that person in particular. The panelists always have the option to pick up any question they want. But if I can just ask from the floor, if you ask the question of a particular person, that would be very helpful. So, on that note, we will start by introducing Marc-André Gagnon. Marc-André is a political economist with Carleton University's School of Public Policy and Administration. He's currently a research fellow with the World Health Organization Collaborating Center for Governance, Accountability and Transparency in the Pharmaceutical Sector, and with the Rational Therapeutics and Medications Policy Group. He holds a PhD in political science from York. His current work relates to the political economy of the pharmaceutical sector and the comparative analysis of drug insurance models. Marc-André, thanks for coming.
Well, thank you. Well, thank you. Okay, so number 2, perfect. Well, thank you, Kevin. Thank you, Katherine, and to the MacEachen Institute for organizing this. So I'm going to be discussing about, well, federal Pharmacare, conflict of interest disclaimer, no relationship with commercial interest. And Diana was discussing this new advisory committee put in place last February. And when it was announced, so having Eric Hoskins chairing this committee, I mean, the guy has been a champion on universal Pharmacare in the past. So many of us got very excited. So, okay, it's about implementing national Pharmacare with a guy who wants universal Pharmacare. The day after, Bill Morneau comes in and says, well, whoa, it's not about universal Pharmacare, it's about filling the gaps. A new national Pharmacare program will be fiscally responsible and designed to fill in the gaps, not provide prescription drugs for Canadians already covered by existing plans. But it's just, wow, you're putting in place an advisory council, but at the same time, you're telling us what will be the conclusions of the report in 1 year. So that was problematic. You had to back down on this. And 5 weeks later, the Standing Committee on Health at the House of Commons arrived with this report on Pharmacare Now, saying it's not about filling the gaps. We need a universal Pharmacare program for all Canadians. The rest doesn't make any sense. And like all the other reports on these issues before, basically the conclusion is always in that direction. And 1 week later, here in Halifax, Liberal Convention, delegates of the Liberal Party voted single-payer universal Pharmacare as top priority, making universal Pharmacare part of their next electoral platform for the Liberals. So that is interesting, but still, we have these 2 visions of implementation of national Pharmacare. One vision in terms about filling the gaps, the other vision in terms of universal Pharmacare. My position in the past has been the problem with drug coverage in Canada is that it is a patchwork, an inequitable, inefficient, unsustainable patchwork with no coherence or purpose. Some people think we can solve the problem by adding more patches, but the core of the problem is that it is a patchwork. So if you look at current drug coverage in Canada, so federal government pays 2% of expenditures, so covering First Nations, RCMP, military, veterans, refugees. Now, when you're doing social policy, you have the working population, the non-working population. And when we talk about provincial public plans, this is mostly to cover the non-working population, so seniors, people on social assistance or low-income people. And now, well, Quebec has its own general coverage. Everybody is covered. If you cannot get mandatory private coverage, you fall on the public plan. But other provinces, what they offer as well is what we call catastrophic coverage. It's just if you pay more than 2, 3, 4, 20% of your annual income for prescription drugs, then the government kicks in trying to help you out. So this is catastrophic coverage. Then you have private plans covering 36% of expenditures that covers 60% of the population, so the working population and their dependents. Well, most of the working population. And finally, out-of-pocket expenditures. This is for people without any coverage, or this is what is paid in terms of co-pays, co-insurance, deductibles. So Nova Scotia, for example, is very typical. So you have 3 main public plans, one for seniors, one for people on social assistance, low-income people, and this catastrophic coverage as well. Now, this is very simple, but super important. If you want to understand the debate right now, this is accounting identities. Every dollar that is spent is a dollar received by somebody else. So households pay for prescription drugs in different ways, through taxes for public plans, or through social insurance premiums, like in Quebec, with private premiums for their private insurance, or with out-of-pocket charges. And you pay for prescription drugs. But every dollar spent is another person's revenue. Now, right now, the advocates of the fill in the gap approach, the stakeholders, very simple. It's drug companies, insurance companies, and pharmacy chains who have a lot to lose if we eliminate the existing waste we have right now in the current system. So, understanding this allows much better understanding of the debate, who is fighting for which position, more or less. Now, if you look at the system in Canada right now, we have what we call cost-related non-adherence. So when you look at access to medicines, you can measure the amount of people not filling their prescriptions for financial reasons or skipping doses. Canada, we're doing very bad. So just after the United States, which is our model of waste and inefficiency. But in Quebec, where you have general coverage, in Quebec, it's still very bad. It's still 8% in Quebec. So it's better than the rest of Canada, but it's not the type of approach we want to in terms of better access to medicines. There's equity issues. I'm passing on this because I learned at only 12 minutes. I thought there was somebody missing, so maybe I will have more time. No. But now you look in terms of cost. So, sorry, my spreadsheets are in French. I mean, United States, the first one, our model of waste and efficiency in terms of total expenditure per capita on medications. Number 2 is Canada. So I broke down between Quebec and the rest of Canada. And you know what? The filling the gap approach, it's let's go from the Canada to Quebec in terms of spending even more and not really achieving a better access to medicines as compared to comparable countries are spending way less on prescription drugs, at the same time having much better access. So all the other countries, they have one form or the other of universal coverage, be it through social insurance or through paid for through general tax revenues. So right now in Canada, we pay 60% more than the median of OECD countries. Quebec is 80% more. And if you look at cost containment over time, so on a basis of 100 in 2000, basically, even the United States, our model of waste and inefficiency, is doing better than Canada and Quebec in terms of containing cost over time. So the issue is not, will we have reforms or not, or should we stick with the status quo? No, the status quo is just unsustainable. Reforms will be happening. The question is, which reform will we see? Now, Sun Life, last week, arrived with their proposal, what for an insurance company national Pharmacare should look like. So yes, we need to build on current private-public coverage, preserving current private plans. We should have a standard formulary for all Canadians, which would be the minimal formulary for private plans. And then every public and private plan should be part of the Pan-Canadian Pharmaceutical Alliance to negotiate prices. Now, let's imagine I represent public plans in Canada. I'm half the market. Maureen, you represent private plans. You're the other half of the market. and we go at the table negotiating confidential rebates with the drug company. So a drug like Repatha, for example. So CADIS says it should not be reimbursed if you do not get a confidential rebate of at least 90%. Now, we're at the table, and what private plan says is that if the public plans can manage to get a rebate, we want to share the rebate with them. If they do not have access to the rebate, so basically they refuse to fund the drug, we will still pay for the drug at full price. Now, try to negotiate a 90% rebate with the drug company if half your market says, well, if you refuse to give us the rebate to the public plans, we'll still pay for that at full price. This is just nonsense. So then the proposal is have a public plan to cover uninsured employees, so mostly the low-income workers. And this is fantastic. Number 5 is just, this is where you fall down your seat. We should have a catastrophic coverage for all Canadians. The public plan should pay for all expensive treatments. It's just, wow. You're an insurance company, and what happens in Canada right now with all these new drugs that are very expensive, that means on your private plan, you can sometimes have a bad risk, somebody with a rare disease that is costing a lot of money. So what we need to do, let's take all these bad risks out of the private plans and dump it on the public plans. And this is just nonsense. What is the use of these private plans if you're not, if you're not building on the institutional capacity to reduce costs, if you're not providing insurance for risks? The thing is, and you're just undermining the capacity of doing things well for the public plans. So in conclusion, private plans will do nothing to contain costs except benefit from public health technology assessment and the negotiating power of the public plans. And basically what they're proposing is to design public coverage as a dump for their bad risks. Let's design national Pharmacare to serve the commercial interests of the private plans instead of serving the health outcomes of the Canadian population, which is nonsense. Now, fragmented system right now, it goes in every direction, no coherence. We need a system with very clear objectives in what we want to achieve. So in terms of objectives, we want to have access to the medicines we need. We want to have value for money. We need a system that is building on value for money. We should get the maximum therapeutic value for every dollar we spend. I mean, otherwise it's just waste. Appropriateness. This is super important. Drug coverage is not only about reimbursing bills. Thank you. Drug coverage, it's about creating a system that is rational, promoting rational use of medicine. I mean, there's issues of under-prescribing because people are not covered. We have massive issues of over-prescribing, massive issues of misprescribing in Canada. A drug plan, a national drug plan, can be a fantastic tool to tackle these issues. I mean, public health crisis. Canada and the United States, 2 countries where we have the opioid crisis. Elsewhere, we have opioids problems. We have a crisis here, and basically people are saying, well, we want plans that accept to reimburse anything at any price. I want to be able to get opioids for my teenager who goes to the dentist for a root canal. No, this is nonsense. We need some guidelines in place, and this is what a drug plan can do. So in the last 30 seconds I have, universal pharmacare for Canada. We need to eliminate fragmentation. One plan for all Canadians. We need to improve equity of access with a national formulary. We need a depoliticized agency, and I'm sure Maureen will talk to you about the issues of when you politicize reimbursement decision, how problematic it can be. You need a clear mandate to maximize therapeutic values for money with a systematic use of health technology assessment, systematic recourse to build purchasing capacity to contain costs, elimination of copays and deductibles based on official prices. Repatha is covered in Quebec, so if we manage to get a 90% rebate, is it normal that the patients still pay a 20% co-insurance rate or a 30% co-insurance rate like in Nova Scotia on the official listed prices before the confidential rebates? That's very, very problematic. And we need a system that monitors prescribing habits and promotes a more rational use of medicine. I'm skipping on Canadian Blood Services as a possibility of a model for a collaboration between provinces to arrive there. Universal Pharmacare is no panacea, but if you implement this with the needed institutional capacities, you improve access to medicines, you improve appropriateness of prescribing, you improve health outcomes for Canadians. Outside Quebec, according to the Parliamentary Budget Officer, it means savings of 20% on prescription drug use, on the cost of prescription drugs, sorry. And it would increase the net disposable income for all Canadians and reduce the labor cost for Canadian enterprises. It would, and especially it would allow Canada to stop being a model of waste and inefficiency when it comes to drug coverage. Thank you so much.
Thanks. Maureen Mcdonald was MLA for Halifax Needham between 1998 and 2016 and served as both Minister of Health and Minister of Finance for the NDP between 2009 and 2013. She has a PhD in sociology from the University of Warwick and has taught in the Maritime School of Social Work at Dalhousie University. Maureen.
Thank you very much for this opportunity. I've been away from the healthcare field now for about 6 years, since 2012, and I practically broke out in hives getting ready, thinking about my experience with the pharmaceutical industry. I want to start by saying that I absolutely support, and I'm directing this at my former colleague, absolutely support a national Pharmacare program for 3 reasons, and some of these have been discussed already. Too many Canadians lack coverage for prescription drugs, and the impact on other parts of the healthcare system is something you have to understand. When people aren't taking prescribed medications as part of the management of whatever perhaps chronic condition they have, they inevitably will show up in other parts of the healthcare system, and sometimes in much more expensive parts of the healthcare system. There are no cost savings here by putting blinders on and not having adequate coverage for people. So there's the human cost, but there's also the financial impact that does have on our system. And the people we're talking about here in Nova Scotia most often are people who are unemployed, they're not in the labor force in any meaningful way where there are the potential for employment plans, young people quite often who have aged out of their parents' plans when they hit 21 and they're not in a workplace where there are plans, and certainly people who are self-employed can be very vulnerable, and the working poor. The current system is a patchwork. This is another reason why. It's inequitable, it's irrational, it's very vulnerable to the politics of the day. Politicians making decisions about what drugs should be covered and for whom is a really bad idea, given that most politicians lack any of the medical knowledge or scientific information on which those decisions should be made. And Canadians are paying far too much for drugs comparatively to other countries, and that's because the current system we have allows the pharmaceutical industry to pick off the provinces one at a time, and we're not able to get the best value for our dollar. And I can give you many examples of that, and perhaps I'll have a chance to do that. So just to give you a little taste of Nova Scotia, Nova Scotia has a health budget of $4.3 billion. The largest area for expenditure for that $4.3 billion, approximately $870 million is on physician services. The next largest is $840 million on continuing care, nursing homes, home care, and then drugs is the next largest expenditure, which is $311 million this year, and an additional $50 million for the social assistance program. And pharmaceuticals and the cost of pharmaceuticals in a health budget has been the fastest growing proportion of the healthcare budget in Canadian healthcare budgets for probably the last 10 or 12 years. So these are the pressures that provincial health ministers face, and here in Nova Scotia, those pressures have been very acute. So, having said I'm in favor of a national program and why we should have one, now I'm going to tell you why I'm very cynical about whether or not we're going to get there, and what the challenges are and what the barriers are. And get your pen out, Diana, because you've got your work cut out for you, my dear. So here is my, there are 6 things I want to talk about that I think are serious barriers and challenges that we have to get over in order to get to a better place, which is a national plan, a more comprehensive and rational plan. So my experience with Big Pharma is that the business model of the pharmaceutical industry is a serious problem in terms of affordable pharmaceutical products for patients. And the marketing practices of the pharmaceutical industry, their tactics and strategies are nothing short of criminal. I've said this many, many times. Their manipulation of patient groups has been well documented, and their manipulation of public opinion in the media is well documented. And their tentacles go very, very deep into far beyond political backrooms, but into the community through the community pharmacies across the country. So let me tell you a story. When I was Minister of Health, we started to negotiate a better deal for Nova Scotians for generic drugs in our drugstores. And the Pharmacy Association of Nova Scotia started to mount the barricades. And one of the things that happened was one day a member of my party caucus, a backbench member, came to me in tears. And she had a letter that was being distributed in her little South Shore community by the local pharmacists to all of the patrons of that pharmacy. And the letter was a letter that told the patrons of that pharmacy that the children's Christmas program party that had been hosted by the Girl Guide Association in that community for 12, 15, 30 years wasn't going to happen because the pharmacy who gave the $2,000 to that little group for that event couldn't afford to do it anymore because of the big bad provincial government who had taken away, I see the former premier of that time, big smile, had taken away the capacity of that pharmacy to earn a living in that community and support that event. that's one example of the way that the industry is able to mobilize public opinion at a very grassroots level to put pressure on government to stop negotiating a change in the business model. And the business model is one where pharmacies put on their formulary particular brand drugs or particular generic drugs, and they get a rebate. They get money to do this. They get paid to stock a certain drug. So that's some of the tactics. I have millions of stories about the tactics and my experience from the pressure from big pharma all the way down. The insurance industry is not an industry that I have as much familiarity with, but we did negotiate a better generic deal. And here in Nova Scotia when I was minister, and in fact, the benefit of that deal had to be split and was split with the private sector, as we've heard is the pattern. One of the real problems, I think, that we're going to have in getting to a national Pharmacare program is motivating the Canadian public to see this as a priority, because so many people are already covered in private plans and in public plans. So this is going to be a challenge. I mean, this is the challenge in the United States around their transformation of their system. So many people are already covered in private plans. So, we have here, certain groups mobilized, but do we have enough to fight an election on an issue like this? I don't know. The other interesting things I learned as health minister around the challenges with respect to Pharmacare is the relationship that the medical profession has with the drug industry. That is a relationship that's not necessarily healthy. It's not necessarily transparent. We need to do more about making it clear what is that relationship. And additionally, I learned a lot from Ingrid, who is here at the School of Pharmacy, and it became much more obvious to me that physicians themselves know very little, many of them, about the drugs they are prescribing, the science and the research around it, and the treadmill that they're on, particularly as GPs, doesn't give them a lot of opportunity to know more about this aspect of their practice. A big problem is going to be the media, dealing with having an informed media, having a media that's not captive by the pharmaceutical industry and the big interest groups. So, time's up. I just have to tell you this one thing. So one day I'm leaving cabinet and going out into the media room, and who's there but Victor Malrick from the Fifth Estate. We all know Victor Malrick. And he has literally brought a dying man into the media room to confront me as the health minister about why this man is not able to get this drug that he could get if he lived in Ontario. And this is a favorite tactic of the pharmaceutical industry. This is how they pick off province by province. They will have a drug that has, really questionable effectiveness. But if they can get one province to put it on their formulary, then Bob's your uncle. They're off to the races, and they'll go after every other health minister, and they will find that patient, and they will work with the physician community to find that patient, because not necessarily these patients come out of the woodwork by themselves. And they will create this public perception that you have a heartless ministry and a heartless government, and the good pharmaceutical industry have this cure. It often is not the case, but it's one of the tactics. So one of the things I worry about actually with the National Pharmacare program is that these tactics will continue, although we need a more arm's length way so that, you take it out of the pressure of putting it on politicians. There'll still be pressure from the pharmacy industry. Anyway, I'm over time. Thank you.
Thanks, Maureen. Katherine Fierlbeck is a McCulloch Professor of Political Science at Dalhousie. She's cross-appointed with the Department of Community Medicine and Epidemiology. She's a Senior Research Fellow at the Healthy Populations Institute. Dr. Fierlbeck's books include Healthcare in Canada, Canadian Healthcare Federalism, and Comparative Healthcare Federalism. Her new book, Nova Scotia, A Health System Profile, was released this May through the University of Toronto Press. Also note that Katherine was instrumental in pulling the panel together, and she is a member of the Research Committee for the MacEachen Institute. So, Katherine Fierlbeck.
Thanks, Kevin. I think you've covered all of my potential conflicts of interest already, so I won't get into them. So what I want to do here is just to say a few words about national pharmacare and the politics of multi-level governance. Now, almost every report that is written on national pharmacare feels the need to note that Canada is the only OECD nation without national pharmacare. And it is, in fact. But you will see a lot of references in these reports to what Canada could do if we followed the path of places like Sweden or England or New Zealand, all of who do a really nice job in this respect. But the problem is we aren't a unitary jurisdiction like these states. Not only are we a federal state, but in fact, we are probably, when it comes to healthcare, we are probably the most decentralized state. And even Australia, which is also a federal state, their constitutional framework allows the federal government a whole lot more scope in terms of organizing and coordinating health policy. So Canada has a whole bunch of inherent institutional obstacles that we have to deal with. So simply assuming that this problem exists because there is no political will at the federal government is quite misleading. What is required at minimum is sufficient political will for at least, 14 distinct political actors here, right? And we know how simple intergovernmental relations are in Canada, right? So the starting point is that we've got all these different political actors, and all these jurisdictions have completely different pharmacare programs in existence, and they're all set up with a different organizational logic, if you will. So some provinces, as Marc-André alluded to, some provinces have pharmacare systems that are based on the principle of catastrophic claims, filling the gap, if you will. Some provinces have a public insurance system or public insurance option available. A lot of provinces, including Nova Scotia's, are needs-based, although what the need is can in fact be determined in relation to age or illness or income or some combination thereof. And of course, Quebec has a different system again based on mandated insurance. So the system is very fragmented across Canada, and even within the province of Nova Scotia itself, there is a whole bunch of fragmentation. We don't have one Pharmacare program. We have a whole number of them. We've got Pharmacare for seniors. We've got Pharmacare. We've got the Family Pharmacare program. We've got community service-based Pharmacare, and we even have a palliative Pharmacare system as well. And each of these programs has its own particular constellation of premiums and copays and deductibles. It's actually quite complicated. Now, the other thing to remember, as has been alluded to, is the fact that the financial burden for drugs for Canadians differs substantially across the country. So one example that I pulled out of a report that I thought was quite remarkable is that a two-person household with $70,000 net income in Nova Scotia would likely face a deductible of $7,000 compared to a deductible in BC of $1,600 or $2,100 in Ontario. So as Nova Scotians, I think the point is that we really have a lot to gain. Again, I looked at CIHI stats this morning and found that we spend, next to New Brunswick, Nova Scotians spend the most on privately funded prescription drugs. So thank goodness there's New Brunswick, otherwise we really would look bad. So we spend $662 per person on prescription drugs. Manitoba spends $391. Ontario spends $580 per person. BC spends $410. And of course, poor New Brunswick spends $759. So the Maritimes have a lot to gain from a Pharmacare program. Now, I'm not going to contest the point that a system of national Pharmacare would be both more equitable and more economical. I think it's clear that it would be. But I do think that advocates for such a system really have, as Maureen acknowledged, really have their work cut out for them. In the first place, you have to recognize that if we engaged in a system of universal Pharmacare, there would be a shift from private spending on drugs to public financing. Now, the Parliamentary Budget Office has estimated that the public sector essentially would have to pony up an extra $10 billion of additional public funds to make this work, right? Where would this come from? Well, it could come from income taxes, it could come from corporate taxes, good luck with that, from GST, it could come from copays or premiums. So what you have to do politically is to persuade the healthy and the wealthy to subsidize the less healthy and the less wealthy through their taxes. Now, raising taxes, as any person involved in politics here, raising taxes, even for a popular cause, is a pretty tough sell. In the second place, and even trickier, I think, provinces, which again have to buy into this, would recognize that their taxpayers, or the taxpayers of the wealthier jurisdictions, essentially would be subsidizing the people in poor provinces, as I just mentioned. And now, while Canada once embraced the idea of regional redistribution as an essential aspect of nation building, which was true again after the Second World War especially, the concept of a social union, which used to be really popular in the 1990s going into the 2000s, we never hear about this anymore. It just faded away from public consciousness. So getting Canadians to buy into the idea of more regional risk redistribution. Let's have the people in the prairie provinces fund the Pharmacare for people in the Maritimes. Again, good luck with that one, because there's a lot of hostility in a lot of provinces about having tax money going out east. In the third place, provincial governments are increasingly wary of federal politicians bearing gifts. They know from experience that what happens when Ottawa offers to cost-share expensive programs, only to back away after a few years, is that the provinces are going to be left holding the bag. And what happens then is that, well, guess what? People don't like having health services taken away from them once they've enjoyed them, right? So when Ottawa turns off the taps, as happened on more than one occasion, I think last time in 1996, the provinces essentially have no choice but to pour money into the gap created by Ottawa, even if they can't afford it, right? Because if they don't, they will be punished by the voters. What do you mean you're going to close our hospitals down, right? So no provincial government is quickly going to run into a beautiful cost-shared system if they think that there's any possibility that they will be left holding the bag down the road. How am I doing? A few more minutes. Okay. There are a number of other issues to be addressed as well. I think our other speakers have covered them very nicely. And again, I just want to reinforce a point that both speakers made, and Maureen's, my stories are not as good, but you are going to have pharmaceutical firms, you're going to have private insurance companies, and you're going to have the pharmacy industry, amongst others, vigorously lobbying provincial governments, telling them what a bad idea Pharmacare is. You have Innovative Medicines Canada, the umbrella organization of the large brand name pharmaceutical companies, with a huge budget and very sophisticated marketing tactics, overwhelming these poor small provinces who may or may not be wise to these tactics. And just out of curiosity, I went on, we have this data, this open data page for Nova Scotia now. You can go and look up all sorts of interesting things. There's, you can look up the Nova Scotia Registry of Lobbyists, which I did this morning, and guess how many lobbyists are being employed by Innovative Medicines Canada, the lobbying organization for pharmaceutical companies. Guess how many lobbyists they have in Nova Scotia alone, lobbying the government on the national Pharmacare system. There's 12 people for little Nova Scotia lobbying the government. And so you can check out the information on each province. So they're spending...
The entire department, pharmaceutical staff.
Exactly. So I couldn't find how much money they're spending on the lobbyists, but I'm sure it's quite a lot. So, and as Maureen has mentioned as well, that's the front door strategy. That's what's more or less there in the open. There's a backdoor strategy where you have the community groups, patient groups enlisted in order to change public mood and public sentiment. So the other issues, again, over-medicalization. The Parliamentary Budget Office noted that if there were to be a system of public national pharmacare, consumption would probably increase by about 12.5%. And the Parliamentary Budget Office also noted that the second highest spending category, for just grabbing one thing, is on antidepressants and mood stabilizers. And of course, as you probably know, there's a highly contested debate over whether there's actually any good evidence of the effectiveness of these drugs. So again, are you going to be allowing people to have more access to drugs that may or may not be effective? The problem with opioids, the problem with overprescription of seniors. Now, simply having a national pharmacare system doesn't mean that there will be an increase in over-medicalization, but what it does mean is that if you think about such a system, you also have to think about addressing appropriate drug prescribing. It really has to be addressed in conjunction with easier access. Okay, so I've hit my limit. I'll leave it there. Thank you very much.
Great, thanks so much, and we've got plenty of time for discussion. So we are going to start with our three students who've signed up for asking questions this week. And I'll just remind people from the community, when you're asking questions, you need to use the microphone. It does not amplify your voice in this room. It amplifies your voice around the world, okay? Because we're live streaming. So if you want to be heard in New Zealand or in Australia or in all those other countries that are listening, then you need to speak into the microphone. So we're going to start with Nicole Mansell.
Hi, my name is Nicole Mansell. I'm a staff member here in the Faculty of Management, and I'm taking this class out of a personal interest in public policy. My question is for Maureen. So you said that politicians should not be the ones making decisions on which drugs are covered. I'm concerned about prescriptions such as contraceptives, gender-affirming prescriptions for trans people who need hormones. If we move to a national pharmacare program, is it likely that that kind of thing will be covered, or what can we do to ensure that it would be? Will that be a fight?
It's a great question. I don't know that I have a very great answer for it. I mean, I think it's clear that if we move to a new system, there will be new issues. There will be unintended consequences. This is certainly so true in the healthcare field. Every time you do something, you can anticipate a whole range of things, but wow, how did we miss that? So this is, you know, an obvious thing. But I think that specifically in this case, these are medications that would support a different kind of treatment decision. So it seems to me that there, you know, that would be accounted for. It would be less likely. And all of the provinces, I think, across the country have now supported these forms of intervention. So I don't anticipate, but there would be unintended, you know, consequences for different treatments. No question about that.
Do you want to tell me what then?
Yes,
No.
I would like to add something.
Yeah,
maybe?
sure, please, go ahead.
It is a super important question. And I mean, there's other issues as well. If we start covering, for example, antidepressants, but we do not cover psychotherapy, it's just we end up providing instant. So these are real issues that needs to be discussed. That being said, the thing is, I mean, it's not universal pharmacare is not a panacea to every problem. It's just if right now the public drug plans are not covering something, well, we cannot take for granted it will be covered by universal pharmacare. If private coverage is already covering part of that, well, you will not be losing that because nobody is saying that universal pharmacare should be replacing or that we could not, we should eliminate private drug coverage. You could have still supplemental drug coverage by employers, for example, provided. So basically, it's just if we change tomorrow, we'd still have the status quo on these issues. So the fight would still need to be done, still need to do this fight on these issues, but then you do this fight at a different level, basically. But the thing is, it's not, universal pharmacare will not change the way things are being done right now on these specific issues.
Great. Now we'll go to Princess Okechukwu.
My name is Princess Okechukwu, first year Masters in Public Administration student. My question is for Marc, and we definitely understand that many government-initiated programs, including Medicare, are financed by taxpayers' fund. Do you think the Pharmacare initiative would add another tax burden on taxpayers? That is, do you see the government increasing taxes when this program is implemented? And what do you think And do you think it is possible to have this initiative implemented without increasing taxes as a result?
What I would like to say first, because the question is just, well, yes, you will be shifting private spending into public spending. And the whole agenda in terms of reducing taxes, what is the objective of reducing taxes? Well, it's to increase disposable income for Canadian households. The point here is that it's not an agenda about raising taxes, it's an agenda about increasing disposable income for Canadian households, first and foremost. So on the issue, how do we finance this? Well, many things I would like to say on this. So first, right now, you know, as if private coverage was just private spending, so it's not the job of. No, why do we have private coverage in Canada? There's a very simple reason, because we have massive tax subsidies for that, because we're not taxing the amount of drug benefits as a taxable income for the employee. Now, at the federal level, it's 13% of private drug coverage that is in fact tax subsidies, maybe half of that at the provincial level, so maybe 20%. And which is, by the way, so we finance 20% of private drug spending by private drug plans, but in a fantastically regressive way. It's just by not taxing the income that represents the drug benefits. So if you're paid $250,000 a year. Basically, your marginal income tax rate is huge versus the other one being paid $20,000 a year with a very low income tax rate. So we're massively subsidizing the one at $250,000, and we're giving almost nothing to the one at $20,000. This is public money we're spending right now. Now, private drug plans, it's 10 billion more or less in Canada. 30% of that, it's for the private coverage of public employees. So everything that is wasteful with these private plans, this is how we pay for drug coverage for public employees. So this is also directly public money. So the thing is, still, there would be a shift from private spending to public spending. In spite of the fact we would get massive savings by increasing the confidential rebates, for example. How do you do that? Well, yes, you could increase the GST, but what about, for example, slight increase of the corporate income tax rate? Because you're reducing labor costs to Canadian enterprises. So maybe Canadian enterprises should be contributing. You could do that by increasing slightly corporate income tax. You can have some types of social premiums or payroll tax that is put in place because it represents also a huge benefit for the working population, that if you get your drugs publicly paid, so make them contribute with a payroll tax, so a mix of the two, for example, the impact would be very small in terms of who is paying for what, but in the end, every Canadian household will be paying less than what they are spending right now. So the thing is, answer to your question, it's complicated, but we can get there.
We're going to go to Barry Tanner now.
Hi, my name is Barry. I'm a first-year MPA student here at Dal, and my question's for Katherine. So transfer payments from the federal government are likely to be a key factor to the success of Pharmacare plans, and transfer payments are often a point of contention for many provincial governments like Saskatchewan, Alberta, and Newfoundland, with fairness and equality being raised as an issue. How can we ensure fairness and accountability in funding a Pharmacare strategy?
Well, fairness and accountability are two huge words, and it gets back to, so the issue of Pharmacare is so politicized because it's an issue of redistributive justice, and this has a bearing for the other question as well. So you're talking about redistributing funds from those who essentially tend to be either as individuals or as regions healthier and wealthier, and you're directing them to people or regions that are, in obvious need of them. So, in terms of how do you ensure the fairness, I would say that fairness is exactly what the issue is. You ensure fairness by implementing a plan that is fair in terms of allowing people who desperately need drugs to have access to them, and perhaps expecting people, healthy people, who have good jobs in regions where there is employment. Maybe the idea is that they should be willing to accept that as a mark of Canadian citizenship. Now, the issue is not, how do you ensure fairness? The question is really, how do you address the politics? Because there's questions of, there's really moral questions about what fairness demands and what citizenship requires. And we haven't been having this discussion about what does it mean to be a Canadian citizen, what not only are the rights, but what are the responsibilities of Canadians to each other across provincial borders. And the accountability question is a whole different matter. It's slightly more administrative, And a lot of that depends on what model you choose. So we really haven't talked in detail about models because models are kind of boring, but you can have a model for National Pharmacare that is essentially based on the Canada Health Act model, where there is federal redistribution to the provinces, and essentially the provinces decide how to allocate that money based upon fairly clear but basic conditions. And if they want to use a slightly different formulary because they have slightly older people, then so be it. So that gives them a little bit. But the question is, how do you know that these provinces are using this money for the purposes that they are to be used for? And that is a question that is an issue, but it's not really that different from the questions surrounding the Canada Health Act itself. So they're not, these questions of our accountability are important, but they're not new questions. They're questions that we deal with, and there are mechanisms that are put in place, and there could be better mechanisms. But it's not something that's particularly novel.
Maureen, you want to give it a go?
I want to say two things in response to this. I think the first thing I would say, thinking politically about this question, is, if I was advising the federal government as they move forward on this, it would be not to talk about this in those terms. Not to talk about transfers, not to talk about redistribution, not to talk about all of those things that get Canadians crazy across the country. What they really need to do is talk about this in terms of getting a fair deal on drug prices for Canadians. They need to think about getting better value of dollar for dollar. They need to talk about economies of scale that would be achieved. I mean, those are the kinds of ways they need to sell this to Canadians. That's number one. And in terms of accountability from the provinces, just in terms of little Nova Scotia, believe me, if there's money coming to this province to improve Pharmacare, it will go to Pharmacare. The province has been desperate to find ways to manage an aging population, a population that has a disproportionate amount of chronic illness. We would spend that money in the way it was intended. And I suspect other provinces would as well. The accountability thing is often cover for not transferring.
Great, thank you. I'm going to take questions from the floor from those who have it. We'll start right over here, gentleman to the left. You just let us know who you are, please.
Thank you very much. My name is Bill Swan. I'm an independent patient. I do not take money from Pharma nor from government, or unfortunately from anybody right now. I run a website called Faces of Pharmacare, and what I do is I collect stories about the impact of not having correct access to drugs. Just very quickly, I had 1 year where I spent $3,000 on copay as a severe asthmatic. My question is for Katherine. You brought up the money, and that's what we talk about. We always talk about how much it will cost. And what I get frustrated by is nobody talks about what we'll save. Because if you look at the private premiums, well, that's just a private tax. The money is sitting there. If you look at the numbers of different administrative systems, just in Nova Scotia, all of that money going to run systems that are duplicative. So I'm just wondering, Katherine, if you could maybe talk a bit about other sources of money.
Okay. I can actually give you a figure on that. The Parliamentary Budget Office have crunched the numbers and have suggested that in the short term, a national Pharmacare plan could save around $5.9 billion. And it's worth noting some of the ways that we could save this. So there's bulk pricing, which we sort of do now, so you can get good prices, the Costco principle, right? You buy a lot and you can get cheaper prices. Then there's centralized negotiation. So provinces can't be played off against each other, which is known as whipsawing. And then there's centralized administration, so there's fewer administrative costs involved, right? So instead of, if we have one agency doing the negotiation rather than 14, it saves a lot of administrative costs. There's the political aspect in which, I mean, you raise a great question too. So the federal government has certain tools available at its disposal to make prices lower. And for various reasons, it's not inclined to do so. But if they were to have some skin in the game, if they were responsible for paying out of their own pocketbook and they felt the pinch, then they might feel a little bit more inclined to get the prices down, because you've seen from Marc-André's schema that we pay amongst the highest prices in the world. So there's some room there to get the prices down. But they haven't to date done it. If they start paying for these drugs, then maybe they'll think about maybe they should put a little bit more effort into making sure that we don't pay such high prices internationally. Greater use of generics, use of a common formulary that really focuses on effective drugs as opposed to not particularly effective drugs. Make sure that, and we talked about not paying the subsidies on private drug plans. So I think you're absolutely right to say that a thoroughgoing national pharmacare system that's publicly funded would have enormous cost savings built into it. Part of the problem is the time lag, I think, in which you have to, it takes money to make money, right? You have to build the system before you can get the money back, and I think politically that's going to be one of the snags.
We had a question. This lady in the second last row. Please tell us who your corporate sponsor is before you start.
I suppose my corporate sponsor is Dalhousie University. I'm an MPA student as well. My question is for Marc-André. Since you ran out of time, I was going to ask you to elaborate more on what stakeholders like Canadian Blood Services role would play in a national public-funded pharmacare system, or what role they wouldn't play, or whatever you were going to say.
Did you plant her?
No.
He was your Carleton University is your corporate sponsor.
Look at that. I can even go.
Okay, but just.
No. Yes, absolutely. Because there's two main paths right now in terms of if we go with universal pharmacare. So one idea is to simply include that in the Canada Health Act. So basically it would be part of Medicare. Basically, keep in mind, Canada is the only country with a Medicare program that does not include prescription drugs, as if prescription drugs were not an essential healthcare service. So basically including that would be kind of natural. That creates some issues. For example, that does not allow any type of co-payments. So if you eliminate all co-pays, then that creates more obstacles for some people. There has to be some co-payments, otherwise people will start using more and more drugs. So that's one of the issues. Canadian Blood Services it's a great example of just collaboration between provinces. And this is what has been happening between Canadian provinces through the PCPA, the Pan-Canadian Pharmaceutical Alliance. So basically, Canadian Blood Services, you have an organization that is federally regulated, provincially funded, that is working at arm's length. So they have their budget, and you become the single payer for Canadian Blood Services. And we pay for 30 billion in prescription drugs in Canada, but $500 million a year is paid for by Canadian Blood Services. And they are the sole providers, so the way they negotiate the prices has nothing to do with what we can get with PCPA. So they get fantastic rebate, and they've been doing a fantastic job. So in terms of efficiency, in terms of accountability, after the tainted blood scandal, there was a crisis, we put that in place, but it works. it works well. And it is a fantastic example of how provinces can get together. If we can have this type of collaboration, that would be fantastic. I hope for that. Otherwise, you will have the big stick approach with the CHA. We give you like, I don't know, 20 or 30% of, we pay 30% of the bill, but we impose on you. Some provinces like Quebec will have more problems dealing with that.
This lady right here.
Hi, I'm Mary Lou Robertson. Hi. For about 10 years, I'm a social worker, and I worked with people who needed help coordinating access to drugs. And right now I'm a drug access consultant, so I left that job and I work independently now. And the problems haven't changed. And one of the things that struck me through this process with the advisory committee and the discussions that have ensued is everybody talks about the vulnerable. And I'd just like to, this is going to lead to a question for either Marc-André or Katherine to expand upon. Because I really do believe the vulnerable we have currently in Canada around prescription drugs has been created by our system. There's nothing that gives you the typical vulnerable patient who can't get their drugs. There are various groups in all walks of life, depending on your disease, your income, where you live. And one of the things that seems to be missing from our conversation is about how policy will translate into the experience of patients at the ground level and how they access their drugs. Because how they access their drugs, how they find out about drug programs, public programs, how they find out about what's covered, how they navigate the complexity of paperwork, filling their drugs at the pharmacy, how they take it and manage it properly. We don't have anything in place in our system that oversees that or manages it well. So my question to Marc-André or Katherine is I want you to step away, and for all the students in the room who work on policy, I want you to show them how they could maybe put themselves in the work from the ground up, build the policy that they will one day work in from the experience of the patients. Can you put yourself in the experience of the patient and tell me, if you were the patient 5 years from now in a national Pharmacare system, what would it look like when you get a prescription?
I've got a short answer, so I'm going to give you a few minutes to think about your answer. But I think that's, again, a really nice observation. And I was reading the other day about how in Canada, in fact, I think it was 98.2% of Canadians either had private insurance or were eligible for public insurance. And so if you take that perspective, you go, well, there's only 1.8% of the population that's left out, so what's the big deal? But in fact, you know, a vast number, I don't remember the number off the top of my head, but a huge number of people who are in fact eligible for public plans don't access them. And the reason that they don't access them is actually fascinating. They don't access them because it's really complicated, right? Just to find out which plan you are eligible for, how you go about finding it. I mean, so just finding out which plan you are eligible for. And you know, do you make too much? Do you not make too much? Then there's the additional level of the barriers that are, say, the deductibles. So some plans, before you can get catastrophic drug insurance, you have to pay out, in the example I gave you was $7,000, right? So even, I think the most generous plan, you have to pay out about $1,500 before you are eligible for catastrophic insurance. I mean, that's a huge amount. Then there's co-pays. I mean, you can co-pay, I think, 20% about for a copay. So if you want a drug, you know, that's, you know, $100, you know, you may or may not, $100 every week, every 2 weeks, you know, that's a nice bite right there. So there's a deductible, there's a copay, and then you might have a premium, like you might be eligible for a plan, but you have to pay a premium. You go, well, that's, you know, that's $800 up front, I can't afford that. So you're eligible, but you don't do it. So the nice thing about a simple national Pharmacare plan for the most vulnerable is that it removes all these barriers, which may be financial, but they might also be just this bureaucratic confusion, right? So I think that would be the first step.
Is that seriously your short answer?
You want to hear my long answer, do you?
Just note, if you sign up for a class with Katherine Fierlbeck, right? That was the short answer. I've got a couple more questions I want to get to, so if you can give us a short and dirty, that'd be great.
I mean, it's a fantastic question. For me, it's really about streamlining the process, making things way less complicated. You know, one of the issue with pharmacists at the counter, it's dealing with all the different drug plans, who has access to what. But for the patient, I mean, can really become a living nightmare very easily, very quickly. So for example, we had adjunct prof Munir Sheikh at one point at SPPA, and he was its commissioner for the reform of social assistance in Ontario, and basically meeting with everybody across the province. And one of the main issue that everybody was telling him over and over again in terms of the reason why some people would still be able to go back to work, but that were staying on social assistance, is because they were scared of losing their drug benefits. It's just, you navigate the system, now, okay, I have this little protection here, so I refuse to do anything, and because I might lose the very little I have. That's the issue of social assistance. Issue of labor mobility. If you work at one place, you have some drug benefits that you might lose if you go somewhere else. This is a big issue as well. So yes, absolutely, these are very important questions. My way of thinking of this is really about streamlining the whole process. Keep in mind, with all these new bad risks emerging on the market, so rare diseases, basically it means that all of a sudden in a private drug plan, we have this person, oh wow, $100,000 a year, and this is, the risk is pooled between 25 people. It's just, it's going to be fun. So what we're saying, more and more private plans are proactively managing the formulary right now, with confidential rebates that can be something very problematic. But before we're saying, you know, private plans, they cover anything as soon as it is approved. It's not true anymore. They're following basically what CADUS is doing, and any private plan might change basically the way they cover things tomorrow if then the cost is too problematic. So the level of complexity right now in the current system is not going down, it's going up, basically. So streamlining the process becomes absolutely necessary.
I think we have somebody online.
So this question is from Andrea via Facebook live stream. Do you think having a national Pharmacare program will cause displaced health focus from prevention to strictly treatment? As you know, most diseases that people die from in Canada and across North America are preventable. Heart disease, cancer, stroke, diabetes, etc. Would enabling more coverage of drugs neglect efforts to address the root causes of these diseases? There was not someone that I was addressed to, but
To me.
I would suggest to me.
Would be happy.
Why don't you go ahead? And I have another question online to get to. So.
That's I mentioned the case with psychotherapy and antidepressants. It's a real issue. Then the question is, should we have public coverage of other essential healthcare services like psychotherapy? Now, one of the argument I've been hearing from private plans, for example, is, oh well, we implement prevention strategies with wellness programs. And I think this is the perfect example of what is wrong with private plans. Because you look at the studies out there, based observational studies, it's just, well, when there is a wellness program, basically people spend way less on prescription drugs than if there's no wellness program. This summer, the Illinois Research Center on Health and Wellness did this fantastic study. So instead of an observational study, they did a randomized controlled trials, basically comparing what was going on, and the results was amazing. There was absolutely no difference. It's just, if you provide a wellness program, what happens is that people auto-select themselves into the wellness program or not, So if you offer one versus not offering one to another population, then the health cost remains exactly the same in the two populations. So this is the type of evidence, the type of expertise I want to know before implementing something at a global level. So if somebody tells you, well, no, wellness programs will save money. No, it will not. Maybe it will increase risk selection, so maybe we can have a more unfair system that is benefiting some. Yes, maybe. But at the macro level, this is not happening. So this is the type of discussion we need to do.
We're almost out of time, but I'm going to take the last question myself because I was wondering if it was going to come up. I'm going to direct it to Maureen. So you may have heard there's an election going on in the U.S. today. And I'm thinking about the rise of populism that we've been seeing. Distrust in government is part of that. Distrust in government's ability to deliver. And we've seen perhaps this expression through the election of the Conservative government in Ontario. So I guess my question to a politician would be, if you were thinking about this issue for next year, is this really the year to run on a big government initiative?
It's a great question. I was at the medical school on Friday, and I talked about this very thing because although I'm not involved in healthcare anymore, I follow it very closely. And I am perceiving a significant, in our province, a significant deterioration of trust in the administration and the leadership with respect to the delivery of health care. So that's the context that I experience. And so it's, you know, I have no conclusion for a national campaign in an election, but we, without a doubt, are living in a time of profound change and turbulence with respect to the general population's faith in the status quo. And any political party, all political parties will be polling, and they will be watching very carefully for you know, where the public is going on these issues. And a party that can capture the imagination, you know, of a populism around perhaps the idea of taking on the lack of accountability of big pharma, for example, might actually do very well. It depends on how things are framed.
I'm sure the elected governments are listening carefully and grateful for your advice. I think they'll be thinking a lot about this. I had dinner with somebody last week who said Pharmacare is going to be the issue of the next election. So we'll watch this space. I think we could go on for probably another 2 hours talking about this. It's such an interesting issue. But respecting everybody's time, and also I'd like to just say, first off, to everybody in the community who joined us for Policy Matters this fall, thanks so much for coming. I hope you enjoyed this series. We would welcome you again. If you really enjoyed the series, don't tell me, tell your friends, okay? So that they'll all come next year. We'll run a series again next year. And I think we sent a little survey out to ask people their views about what kind of panels we can have next year. We're always open for advice and suggestions. On that note, I'll say that, as is the custom, we'll offer some tokens of our appreciation to our guests after the roundtable at the MacEachen Institute that we'll be having later this afternoon with some second-year graduate students. In the meantime, please join me in thanking the panels on a great discussion on Pharmacare.